Hello, everyone. I'm Vikas Sani, president of the Lown Institute. We're delighted to have you all join us for this year's launch of the Lown Hospitals Index. Because the Lown Index is about social responsibility, we wanted to kick off this event by asking you, what do you think is the most important issue in hospital social responsibility today? So you should have the question in front of you. It's a poll, so take a look. Is it equity, debt, consolidation, burnout, too much regulation, not enough? We'll see your answers in a little bit. In the meantime, let's talk a little bit about the program. This is the 5th year that we've issued this ranking of the most socially responsible hospitals in America. The ranking has 54 submetrics, and they're organized across 3 core categories: equity, value, and outcomes. And while we hold launches for some of the individual metrics at other times of the year, this is the launch where we integrate all of the data, where it all comes together and a comprehensive update of our website takes place. So you can actually visit that website now and view the 2024 rankings of over 3,500 hospitals and hospital systems across those 54 metrics. And you can filter them by state, hospital characteristics, regional characteristics. So I think it's quite useful and fun to play with. We've made some important updates to the index this year, so let me talk a little bit about that. One thing we've done is we've separated acute care hospitals and critical access hospitals. They're ranked separately, which I think is a great improvement to the rankings. Both types of hospitals are really vital to healthy communities, but they're also very different types of institutions. Critical access hospitals are very small. They're usually in remote locations. They have limited patient volume, and that can create difficulties in really creating a comparable yardstick. So in the slide, we've highlighted where you can toggle between the 2 types of hospitals, so if you want to see them separately. Another thing we've done this year is we've added a new metric under clinical outcomes. That's for acute care hospitals only. And that metric is the rate of unplanned admissions within a week of outpatient surgery. Now, as many of you know, outpatient surgeries have moved out of the hospital into the outpatient setting. And so we thought it's important to ensure that the quality of clinical care is maintained and that we can track that. So that's what we're doing. Lastly, we've updated the weights of our 3 main categories, with equity now receiving a weight of 40% instead of 30%. We made this change to ensure that equity measures have adequate importance within the composite. The other 2 metrics track each other, and we noticed that equity needed a boost for it to actually be at the importance we originally intended. So one of our biggest takeaways of the past 5 years that we've been publishing this index has been, if you want to measure what matters, then you really have to include equity. When we were first creating the ranking, we thought, if health equity is so important, where are the measurements? Why isn't anyone measuring it? So we set out to create metrics that capture more of what hospitals do for their employees and their communities. Metrics like racial inclusivity, pay equity, and community investment. As a result, we're able to identify organizations like St. Luke's University Health System in Pennsylvania, which is our number 3 ranked hospital system this year. When St. Luke's conducted their community health needs assessment, they found that rates of food insecurity had increased across all the counties they served. And in some counties, it had increased as much as 45%. Their Department of Community Health got to work partnering with local groups, and by this year, they'd established food access initiatives in all of the high-need communities. Each of these food access hubs serve over 140 households a month with services such as on-site pantries, mobile food distribution, connection to SNAP benefits, and referrals to existing food banks. So we're delighted to have a representative from St. Luke's here today who'll tell us more about that in a few minutes. We were also the first, and to my knowledge, the only ranking to measure hospital success at avoiding unnecessary tests and procedures. One hospital that does particularly well on this front is Metro Health System in Cleveland, and they rank #1 on avoiding overuse in their state. Their rate of unnecessary coronary stenting is half the Ohio statewide average, and their rate for unnecessary head imaging for fainting is 1/3 the statewide average. One secret to their success, I think, is their participation in value-based payment models. Over 7 years, the percentage of Metro Health's patients affiliated with some kind of value-based payment system grew from 5% to 75%. By paying more for value rather than volume, they've saved Medicare $37 million over 5 years. So I'm looking forward to talking about that as well, since we have a representative from them. And finally, even as we're proud of our novel metrics, we also recognize the importance of providing great clinical outcomes for everyone. So for the index, we created our own measure of clinical outcomes using a machine algorithm to adjust for patient risk. This allows us to better compare outcomes across patients when they have the same medical needs and comparable risk. We can learn from hospitals like University of New Mexico Sandoval Regional Medical Center, which ranked #5 in the US for social responsibility and #1 in their state for clinical outcomes. University of New Mexico reduced their readmission rates by connecting at-risk patients to transportation and temporary housing after discharge, among other programs. Another good example is their sepsis reduction program. They brought their emergency and internal medicine teams together, and they reviewed all sepsis cases, and with feedback to providers, improved system processes, and identifying ways to improve, they reduced sepsis deaths by 50%. And to any clinician, you got to admit that's an amazing result. It's not easy for hospitals to do well on equity and value and outcomes, but that's what you need to do to make the Lown Index honor roll. Out of the 2,758 acute care hospitals on the index, 154 made it this year. So leaders from 2 of these honor roll hospitals are here today, so let's introduce them now. Dr. Nabil Shahade is Executive VP and Chief Clinical Transformation Officer at Metro Health in Cleveland. Dr. Shahade's responsibilities are heavily focused on equity, including population health, digital health, senior care, and the Institute for Hope, which focuses on identifying and alleviating non-medical social drivers of health. Dr. Rajika Reed is VP of Community Health at St. Luke's University Health Network in Pennsylvania. Her department oversees the Community Health Needs Assessment, which serves as a guide to support strategic initiatives for community health. And finally, we're happy to have on the panel for a second time Dr. Paul Haddis, who is a senior fellow at the Lown Institute. Dr. Haddis was previously a professor at Tufts in the Department of Public Health and Community Medicine. In the last 6 months, he's been a go-to resource for media coverage on the Steward healthcare debacle, which we'll be asking him about later. You can read a lot of his writings online related to Massachusetts health policy in Commonwealth magazine. So we wanted to give each of you a chance to respond to the poll question. Based on your experience in your job, what do each of you see as the biggest issue in hospital social responsibility today? Rajika, let's start with you.
So I think, equity plays a huge role because the community needs are vast. There's a lot of need in the community. And I think what we see that comes through our assessment is really looking at those big buckets and working in collaboration with people to address a lot of those needs.
Thanks. And Nabil, what about you?
Thank you, Vikas, first of all, for introducing us to this panel and including us. It's my honor to be here and representing Metro Health. I have to agree that health equity is rising to the top today, but I did not see the entire poll question, and I'm wondering where value-based, why it was not. Was it there? Was it included? And if it was not included, I will put value-based care hand in hand with equity. And I can talk a little bit more about why I think so.
Well, take a minute now. Why do you think so?
Oh, absolutely. So before joining Metro Health about 8 years ago, I was in a health system where we were fully capitated, and I understood what value-based care should look like. But we were not a super safety net hospital and a high academic research institute at the same time. While I understood what value-based looks like in a non-super safety net hospital, I did not have the full appreciation about health equity and why you need to go upstream to really be able to optimize your value that you're providing. Because if you don't have access to care for any barrier for health, you're not going to get to where you need if you're accountable for those population to improve their health outcomes. So I truly believe they go hand in hand.
That makes a lot of sense. I'm sure we can dive in more to that. Paul, your thoughts? What makes a
So
hospital
I'll give
socially
this.
responsible today?
Well, let me try to get to it by talking about the way I look at the index and the various things that come of it, but including the equity issues. One is a hospital is not a hospital generally unless it does patient care. So the outcomes related to quality, an important part of the Lown Institute's measures, make sense, I think, intuitively to any of us who think about hospitals. The value notion, and in terms of what are the incentives either that the hospital or doctors have, and sometimes to under fee for service to do a lot of care to maximize revenue, but does that come up against value notions as the Lown Institute has been involved with many years of too much care? But these equity notions, in the various ways that the Lown Index describes, if you think about it, in some ways, what distinguishes what we think we're getting from many of our nonprofit hospitals, not that for-profits don't care about equity either, but we're awarding tax exemption. We're sort of saying, hey, but for some help financially through exemption, some of these equity issues might not naturally happen as, pursuit of equity results might not necessarily happen on their own based on sort of a pure economic agenda. So we expect, and we should expect more from our nonprofits. At the same time, that our for-profits who come in various forms, live in a world where they have expectations too, in terms of if they're going to exist and meet community needs. So those equity issues, I think, are becoming increasingly important, and I see why the UVCAS and colleagues have decided to weight it a little bit more in this year's overall index.
Thanks, Paul. So let's dig into equity a little bit more. In our experience over the last few years, it's often the missing piece, especially in some, not all, but in some major brand name hospitals and academic medical centers. Before we do that, let's see the poll results. What did the audience think? Well, this is a case of selection bias, I'm sure. Nearly 60% said health equity. And you're absolutely right, Nabil, we didn't include value-based care. And I think that's an oversight, but it also suggests it's not high on the radar of some in our audience. So there are a lot of different ways of thinking about equity, thinking about the relationship of upstream drivers and health outcomes. But this is a question for you, Rajika. Community health needs assessment is sometimes, and maybe too often, a check-the-box activity for hospitals. But you and your team obviously take it pretty seriously. So how did you ensure that there was community input into the process?
This is one of my favorite questions, actually. St. Luke's University Health Network is deeply committed to the community health needs assessment process. And we conduct all the assessments in-house for all 15 of our campuses. And our network board, campus presidents, and senior leaders all play vital roles in that process. We gather both primary and secondary data. Our primary data, so the data that we collect, comes from three main sources. Key informant interviews, which are conducted with key folks in the community, folks like mayors and superintendents, folks at those high levels that have the vision for the community. And then we also have community forums at each of our campuses with stakeholders, so our community partners and others that we don't work with too, we include, to come together and speak on behalf of the people they serve. And then these two processes, or these two data gathering processes, really gives us a good, qualitative base for our data, for our analysis. It's rich data that we collect, and we also conduct a survey that's open to everyone in the community, 18 years and older. At the last community health needs assessment round, we had 11,523 respondents. So it was a great pool of data for us to analyze, and we couple that with the secondary data, and it really allows us to speak to the needs for the whole community that St. Luke's University Health Network serves.
Wow, that's really impressive. That's excellent. Thanks. So Nabil, I mean, I have a little experience 20 years ago with something like value-based care. And so I can see, I think it's sort of intuitive to me, how if you're going to really cover a large population, an inclusive population, you're going to have to address upstream social determinants, because without that, it's going to be really tough to run a risk contract, for example. But the question really is, how do you make sure that you have those kinds of contracts? Are you seeing that now? Is there a wider net being thrown for who is eligible or who is sought after in value-based contracts, both at the patient population level and the provider network level? How's that working?
So we've been on a journey, and you stated correct when you introduced us at Metro Health. When I joined 8 years ago, we were less than 5% of our care wasn't value-based. It was mostly fee-for-service. Although I can argue before the expansion of Medicaid in the state of Ohio, about 30-40% of our patients were self-pay patients, which really are the ultimate value-based contract that you can ever have. And that really will push you into equitable care and looking at all. And I think this is part of the secret sauce that we have in making that to work. So it takes intentionality to move. It's just not going to happen on its own to move from a fee-for-service to a value-based. And I truly believe that journey is probably one of the most difficult for health systems that are so entrenched and hooked on a fee-for-service, on per-click measurements, per procedure measurements. And that's why you see us, when it comes to value, we rank extremely well, because actually we state that we are the lowest cost provider in the state of Ohio. We know that that's been measured by our Department of Medicaid, and we have a large population of Medicaid, and we consecutively for the last 6-7 years since that measure has come out, we are one of the lowest provider we are the lowest for our size of system. So it takes intentionality and incremental enrollment in those programs. We started with Medicare, with the traditional, just like everybody else does with the fee-for-service Medicare population, because these are well-established programs. But as you gain knowledge in this population, as you build your infrastructure, you're going to say, I'm building that infrastructure, so why not to expand? Why not to expand? And that's how we went on that journey, start from 5%. Actually, more than your numbers are, I will correct them a little bit. We are more than 90% of our patients are in some sort of a value base. Close to 80% now are in a total cost of care value-based, because not all value-based are the same. And also total cost of care doesn't mean capitation. Only 10 to 15% of our patients are in capitation models. So it's a journey, and you gotta build yourself, your capability to get to that journey. And we can dig deeper as much as you want in more detail.
Bill, can I ask a quick follow-up to you? Have specialists been part of that journey too?
Oh, absolutely. We are one 10-level health system. All providers, physicians, not APPs, etc., are under the same tax ID, and they're all included in our ACOs.
Excellent. I think that's a key driver. The other is, and then how's the governance structured, but we won't get into that right now. So Paul, you know, you've got a long and deep understanding of the situation in Massachusetts. And, you know, one of the themes that keeps coming up whenever we do our rankings is the tension between financial performance and the need to do well, and meeting the mission or the need to do good. And of course, our thesis is one can do well, or at least well enough to stay afloat, not necessarily to, you know, drive a Rolls Royce, but to stay afloat and meet the mission. But how do you see that playing out in Massachusetts? What's your experience with the equity issues that hospitals face here in relationship to their financial performance metrics and their needs?
Well, I guess if I could characterize our hospital system overall, and system is the right word, because many of them are systems. We have fewer numbers of independent hospitals left, but we've evolved a situation where we have haves and have-nots in terms of financial resources. And the have-not side includes both a group of non-profits who you know have been struggling in cases for many years, as well as now for-profits, at least for the last more significant numbers in the last decade or so, as they entered the private equity model. But the have and have not issue sort of in some ways transcends, I think, some of the challenges that you'll even see in the way that hospitals come out in the Lown Index area, as you noted. Those who are financially challenged, often in communities that are more racially, ethnically diverse, often with higher proportions of public payers, they tend to do better, you know, on the equity side measures, you know, in terms of community benefit, because sometimes that, you know, ties into Medicaid dollars as a portion of your total revenue, as well as including populations that live nearby the hospital. They tend not to do as well, those kinds of institutions, at times, on some of the quality and or even patient safety. Not always, but you know, some of those efforts do take more investment. Although, you know, I'll make this observation: some of our largest and most prestigious teaching hospitals, and you can see this if you go into the Massachusetts hospitals on your index, they don't do all that well on patient safety. So that's, you know, it's a complicated issue, but they tend to have more resources, you know, and also, you know, by the fact that they've had a long history of, you know, often attracting excellent clinicians, tend to do well in some of the other, you know, measures of outcome care, where those large teaching hospitals tend not to do so well in inclusivity. Most of them do poorly when you look at the ratio of how CEOs are paid, often incredibly generously compared to other workers, including your comparative housekeeping staff. And some, because those revenues are just so large, and even though they pride themselves, you know, in saying that, you know, they do a certain amount of free care, although we have less of that in Massachusetts because of our, you know, state of significant health insurance coverage in the state, or they even say they make commitments to Medicaid. It's so dwarfed by their other commercial revenues, they won't rate as high on that part of the Lown Index. And then the inclusivity is somewhat variable. Some of the institutions who live or reside near communities that are challenged will care for significant proportions of them and do okay. Others sort of attract patients from the suburbs in some instances and sort of skip over the local community. So you tend to see that, I think.
Thanks, Paul. That's really helpful. So we got a few minutes for a few more questions. There's one from the audience. This is for you, Rajika, which is, how important is it to do your own community health needs assessment versus contracting it out? And with what frequency should it be done, or do you do it?
I believe that it's very important for us to do our own assessments. The assessment process is really an exercise in partnership development as well. And I do think that, we have a lot of people, it takes a lot of trust from our partners to be able to speak honestly on what the needs are. We have government officials, we have community partners, and we all play well in the sandbox together because we've built that trust within the community. And to truly understand the needs, you really do need to have that, so you can have that open conversation. So I do think it's an important piece of the community health needs assessment. And as far as how frequently, we conduct our assessments every 3 years. The Affordable Care Act actually mandates that all nonprofit hospitals conduct their community health needs assessments every 3 years. And so that's what we do at St. Luke's.
Thanks. I'm going to try to sneak in one more question before we move on. Nabil, let's talk a little bit about one of the metrics that your hospital did really well on the Lown Index, and that's avoiding overuse. Something I know a little bit about, and I'm curious. As you've developed these programs, I know you probably started from a culture that was already kind of amenable to that way of thinking, but as you moved forward, what kind of pushback did you get? Did you get any?
No, I get that question quite often. And culture plays a significant role into this. And it is, so I keep on saying, being a super safety net hospital, create that culture, but also being a high academic center. You have the medical student, the resident, the fellows, that they keep you in line of what is appropriate and what's not appropriate. And I think a combination of those two are really right to get the right program and to lower your utilization. I truly believe that's part of the secret sauce. Two, some of our most costly patients, the highest utilizers of all kind, and many of those will be on your list, usually lend themselves to a special program that we have dedicated teams that just take care of them and coordinate their care on the outpatient, like an outpatient intensivist unit that we have in place, and really make sure that only the appropriate care and at the best time and place is provided to those patients.
Got it. Excellent. Well, keep it up. So let's turn to our countdown list. But before we do that, just a word from our sponsor, which is us. If you're a hospital leader or someone who cares about social responsibility, you'll want to subscribe to our free monthly newsletter, Hospitals on Purpose. The newsletter gives you first notice about Lown Index releases, interviews with top hospitals, and what's happening in the latest hospital policy and research arenas. So you can click the link in the chat to subscribe. And now, without further ado, let's get to our countdown. Here are the top 10 acute care hospitals for social responsibility in 2024. We also have a top 10 list of critical access hospitals, and that's available on our website now. So at number 10, we have Sonoma Valley Healthcare District in Sonoma, California. This is the second time that they've appeared on our honor roll, meaning they're a straight A student. St. Luke's Hospital, Upper Bucks Campus in Quakertown, Pennsylvania. That's number 9. Number 8, Methodist Medical Center in Oak Ridge, Tennessee. It's also their second time on the honor roll. Number 7, Cedar City Hospital in Cedar City, Utah. Number 6, Suburban Community Hospital in Norristown, Pennsylvania. It's their second time on the honor roll. Number 5, University of New Mexico Sandoval Regional Medical Center in Rio Rancho, New Mexico. Number 4, Adventist Health Ukiah Valley in Ukiah, California. Number 3, UC Health Greeley Hospital in Greeley, Colorado. And they've been in the top 10 2 years in a row. Number 2, Baylor Scott White Medical Center in Pflugerville, Texas. They've been on the top 10 also 2 years in a row. And number 1, Duke Regional Medical Center in Durham, North Carolina. That's the second time they've been number 1 on the Lown Hospitals Index. So it's a congratulations to all these hospitals, all these winning hospitals, and all the others who've done so well. So natural question. What do all these hospitals have in common? Well, they're all nonprofits this year. I will say in prior years, we've had a few for-profits, but they're all nonprofits. 2 are government hospitals. And I think there is a little bit of a pattern, at least with our honor roll hospitals, that we can talk about. I don't know what it means exactly. 3 of these hospitals are in the mountain region. On the honor roll, there are more hospitals in mountain states like Utah and Colorado than one would expect. Maybe that's culture. I'm not sure. Interesting thing to think about. Most of these hospitals have been in the black for the past few years. They're not all losing money, despite their equity scores. Only a few have had consistently negative income, such as Suburban Community Hospital, and that maybe explains why its system is actually planning to turn that into a micro hospital and removing its inpatient beds. So, you know, it's an interesting mix. Looking for patterns, it's hard to find some. The sizes are small, medium, large. Paul, what do you think of our top 10?
Well, couple of things I
figured
observed.
something out?
First of all, there's no major academic medical center in that top 10. Just to be clear, the Duke Regional Hospital is not the Duke University Medical Center Hospital. It's a community hospital.
Right, in the top 10, correct. They're definitely in the honor roll. That's where Mount Sinai is.
Right.
Yeah.
The other observation is none of them are in large cities. You know, there might be some reasons for that when you look at all the measures. You know, for example, I would imagine they all have high scores, but it's easier to be inclusive in an area where you really are the hospital maybe serving the community rather than people either skipping over from the institution's perspective who lives near you locally to reach out to, let's say better paying patient population. So I noticed that about them. We'll get to this if I talk a little bit more about Massachusetts, but I hear your observation that most of them is, well-managed hospitals, which they probably have to be consistently doing well. Tend to at least have a margin. You do need a margin to be viable, to borrow and do those kinds of things. In Massachusetts, where we have some of the lowest operating margins in the country, a good number of our hospitals in the top group actually tend to lose money consistently each year. So a little bit different. So let me stop there for now.
Yeah. If you want, Nabil, Rajka, do you have any thoughts on that list? It's sort of interesting. I'm not sure what you could make of it. But,
yeah, it is pretty interesting. And I also did not see a large health system on that list. And what I thought when we made the honor roll, I thought, and I looked at others in Ohio, like all of our hospitals. So we have 5 different hospitals, 25 major outpatient setting, 60, 70 different spots to get care in the community, all under the same tax ID. So when you all rank us, you're ranking the inner city, the suburbs, all over, which I believe is a little bit more challenging when you look at those metrics.
Yep.
The practice does vary from one center to the other, from one community to the other.
Yep.
But
I think that's a fair point, and I think Paul's point also, I think is insightful. These are individual hospitals, and I think we do have systems rankings. We chose not to talk about them today, but in fact, systems rankings will tend to include many different locales and demographics, as you point out, Nabil. Rajka, any other thoughts before we move on?
I don't have anything else to add.
Okay. So I want to see if we could talk a little bit about a topic that's really hot in the media these days. So one thing is that this year, unlike prior years, we did not have any for-profit hospitals in the top 10 for social responsibility. I think in one year, the #1 hospital was a for-profit. Although interestingly, speaking about culture, I heard that for-profit actually converted the other way and went back to being a nonprofit recently. So it's something about their attitude and their culture. But in any case, how do for-profit hospitals do on the index? Well, I think you can see overall they're underperforming. There are fewer for-profits on the honor roll, and there are more with D grades than you might expect on a proportionate basis. Now, I think the biggest story in the for-profit world this year has been the growth of private equity. And here in Massachusetts and other parts of the country, the fall, I don't know if collapse is the right word, but it's certainly a dramatic shift in the fortunes of Steward Healthcare is really a cautionary tale. So, the way I see it, their private equity owners extracted very high rents for the underlying real estate. And that left Steward hospitals struggling to pay their bills. We know from stories here in Massachusetts, they face shortages of supplies, and in some cases that threatened patient safety. Meanwhile, the CEO of Steward was publicized for 2 multi-million-dollar yachts that he had purchased with the special dividends when they reorganized the system. So here are the major hospital systems that are currently or recently owned by private equity firms. And our index results there you can see are mixed. Overall, only one received an A in social responsibility, so maybe that's reflective. But most interestingly do pretty well on equity, with all of them getting A's or B's. Now, this may indicate that these are hospitals that serve lower income populations, and it may be a correlation that those hospitals are more financially distressed, more available or vulnerable, depending on your point of view, to acquisition by private equity. On outcomes, only one system gets an A. And I think there has been other research, not ours, that's shown that rates of harm have increased, patient safety metrics have increased in hospitals after they've been acquired by private equity. So maybe the fact that only one of these systems gets an A on our outcomes is not a big surprise. The other area where these hospitals don't do well is in value. Nobody really gets an A in value. And I think this raises interesting questions about the rationale for PE acquisitions, the overall motivation, what kind of reorganizations take place. Are they clinically efficient or are they financially efficient reorganizations? So it's interesting that, private equity is supposed to increase efficiency. Question is what kind? So we're certainly not seeing it on value. So naturally, Paul, at this moment, I think I have to turn to you. You've been following the situation at Steward. What are your thoughts about the performance we're showing for private equity hospitals? It's not horrible. It's not great. There are a few subtle hints. What do you think?
So first, I'll make this observation about all, let's say, hospitals, publicly traded or private equity, which is, I think one of the things that has saved us on the quality side in a lot of these places who are really financially stressed, and I'll come to our own situation with Stuart in Massachusetts in a moment, is really the ethic of the providers, the nurses, and even the docs, that despite the challenges sometimes of the institution, and it's certainly been true here in Massachusetts, how dedicated the nursing staff has been throughout all the Stewart hospitals, through thick and thin, and that's an important consideration. I guess first thing I'll say is I'm not surprised by the overall grade that the Stewart system, let's say, received here, and I'll address that in this sense. On the equity side, if your hospitals like the Stewart hospitals, which started as have-not institutions, so before they were Stewart, they were really part of an ailing Catholic hospital system owned by the Archdiocese of Boston, hospitals that were always struggling a bit financially. They tended to be in localities where they served poor patients, high proportions of patients on Medicare and Medicaid, and often racially, ethnically diverse populations in some of those localities. So the fact, especially as Stewart's been challenged to hold on to any volume, the fact that it's then getting volume, from its local communities I think is going to help it on the inclusivity side. It's helped on its community benefit scoring, not because its hospitals anymore really do the kind of upstream work that Rajika is doing in terms of social determinants, but just even though Massachusetts has less free care, and the free care and the Medicaid proportions is really what sort of beefs up their community benefit rating. And although we know at the system level, there's huge returns for the executives at that level. I don't know exactly how the hospital CEOs are paid, but based on some of the hospital reports, it seems like they're paid in some ways proportionally relatively high, earn them often C grades in that particular area. But there is variability in terms of the value. Just to jump into this, if you look amongst the Stewart hospitals in our state, there is some variability on the value and the outcome side, although there's also a lot of missing data for a few of the hospitals. Some of them don't report patient safety adequately. Some have other numbers missing, so you do worry about that. So I guess where I'm going with this, and the worries, and I'll stop here after I make this comment, with private equity, in some ways, those hospitals got there because they were ultimately ailing. They couldn't find local nonprofit buyers, so to try to make it in the world to come, they turned to a buyer who said, we'll help you make it in the world to come. And there was a lot of hope. But as we've seen from the newspaper reporting and such, there's been a lot of extracting of resources and then now negotiated high rental payments facing those institutions, which has forced them now into bankruptcy. And despite that, I would say those hospitals have been trying to hang on and do a decent job. And my hope is that because of that ethic, and we hope to now, and we'll probably learn this in a month, those hospitals likely will no longer be in Stewart's hands. Some might close, but the ones that remain open there's an effort afoot to try to get them into new ownership, often nonprofit hands. One hopes that even though they've been resource challenged and even greatly more starved, that they have something to build on based on some of the things that the Lown Institute found in its ranking. So my thought.
Thanks, Paul. So I want to ask a very kind of super high level question, and Nabil and Rajika, feel free if you're so moved. Yeah, let me just ask it. It's this, as you do your work, this transition from volume to value, this transition to more prevention and upstream stuff, all of that requires some infrastructure. And infrastructure is by definition a capital allocation. It is something that requires some time and effort and money. And the question is, for healthcare that's already at 20% of GDP, how and in what way do we get capital for the kind of transformative investments that we really need? And private equity is positioned as a source of capital in the end. That's what it's about. And those people who do deals with private equity are doing that for that reason. So my question is, if you if you, your institution or your peer institutions really wanted to turbocharge your efforts, would a bolus of capital not help? Wouldn't it move things forward? And isn't really the question on the table not whether you need capital, but what the strings are, who's calling the shots, and what the accountability is? Not to ask a leading question. Nabil, what do you think?
So first of all, of course you need cash, but where is that cash coming from? I rather get the cash through the payer, whether it's the government payer or a private payer, because I want to be accountable to my outcome on the care that I'm providing, and that's how I'm gonna return my cash back, and not to a private equity or anything else. So, but look, there is, I keep on saying it, there's a lot of money in healthcare around. We spend a lot of money in this country on healthcare. The question is, how do you want to spend it and how you want to create the value? If you can align and you can understand the business and you can align where you can create that value and you really understand who you're creating the value to, and then reap the benefit and the rewards that comes with it, which is monetary reward, that then you can invest more in your infrastructure. And besides, a lot what I see, people invest in their infrastructure for population health and really not diving and taking the risk. If you're gonna make that investment and keep a 95% of your care in a fee for service, then the investment is not gonna reap its benefit. What's the point?
Yep. Understood. This has been an ongoing dilemma over the last, gosh, 10, 20 years. You know, I mean, I won't go into it, but people have been talking forever about how difficult it is to have one foot in the fee for service canoe and the other foot in the value canoe, and it's really hard to navigate.
But there are things that
I
make win-win in both, right?
Yeah,
There are
understood.
things that health system that going through that transition have to find a win-win in both. There
Yeah.
are programs that people believe they are still in the fee for service, but they're all value-based, like being paid on a DRG in the hospital. Okay, that's
Yeah.
actually kind of value-based. It's just like you are optimizing the care for that admission. Okay, so length of stay, there are a lot of initiatives. So this, I think, is a little bit overrated, this difficulty for moving from one to the other. It just, you have to find the win-win situation when you start small and create those value, and then you build them.
Yeah,
Thanks.
I think
Rajika?
our network, the mission of St. Luke's University Health Network is very aligned to the mission of our department. And our board is completely local. You know, it's made up of leaders, community leaders, and so it's natural almost for St. Luke's to have such a huge focus on the community and ensuring that our community is well. And it really then becomes a network of effort since all those pieces are aligned so well. And from a community health perspective, if we're not delivering accessible, quality, cost-effective care, it's not setting up a system to be equitable, really, because equity is about everybody reaching or having access to the same level of care and that everybody has, as opposed to, building systems within systems.
Yeah, thanks.
Let me add, I think both.
Sorry, Paul.
Sure.
We only have a few minutes left and we have some audience questions. So let's turn to some of those. First, it's kind of a two for Rajika, but let's tell us a little bit more about the food security project. But before you do that, a question about how hospitals could actually be held accountable to take the community health needs process more seriously. In other words, at the moment, it's sort of voluntary. What
Mhm.
what could be done to make hospitals more accountable for the process itself?
Actually, it's a requirement by the IRS. So I think a lot of hospitals do contract out. I think understanding the value it adds to the practice and your community building as a health system is really important because I think that piece is overlooked. Um, and I think part of that is, we've had consistent leadership at our health network for the last 30, 35 plus years. And our department was developed so long ago in the late 90s that we've been doing this for a long time and being consistent in our community. And so that in itself is a really big plus. But having those assessments really provides even our partners. We have partners all the time who tell us that they use our assessments because they don't have the capacity to run assessments like that with the rigor and the data that we do. So I think understanding how some of those processes that we have to do as hospital systems can actually benefit our communities and our relationships in our communities is an important piece as well.
Thanks.
And you asked about our food security, is that right?
Yeah.
So we actually received an award from the hospital HAP, which is the Hospital and Health System Association of Pennsylvania this spring. And like you said, we had our community health needs assessment in 2022, which COVID really exacerbated a lot of the food insecurity issues. And so we used the Feeding America model which advocated for an assessment followed by referrals and partnerships. So we did just that, and we built systems within schools, like pantries within schools, summer meal programs, and then also did farm fresh produce boxes and weekend bags. So St. Luke's has a 14-acre organic farm on one of our campuses, which is super exciting for everybody. And it's novel in that there aren't many hospitals that have farmers on their payroll, but we use that produce in our cafeterias and for our patient meals. We also use it for our programs in the community where we have food boxes that are packaged and delivered for whether it is our diabetes programs or our summer feeding programs. And then we also do CSAs for our employees with it. So just thinking outside the box a little bit and doing some of those pieces that can then align, because it's not about how much money we can throw at it all the time. It's really utilizing some of the assets that we already have.
Thanks. Another audience question. It's directed to me and to Nabil. And I think this is a legitimate concern. The term value-based care has been hijacked in many ways by some Medicare Advantage plans that are anything but. How do we reclaim that term, or maybe we need some other term to really distinguish true value-based systems from efforts that are, more cynical, according to the questioner, I might call it, that are gaming it more, without delving into all the technical details of how that's been done. It is pretty clear that there is a substantial fraction, maybe the majority, Medicare Advantage plans that are really not practicing the kind of value-based care that you and I might advocate. Nabil, what do you think?
I do agree with whoever asked that question. And what needs to happen is transparency on the total cost of care, transparency on the quality and the service that's provided, and transparency on the equity or the disparity of the care that's being provided. If you have that transparency and you report on them on a regular basis on the patient population. So if you're providing a low cost care, providing high quality, you gotta define what the high quality is, because not everybody defines high quality the same way, and good patient satisfaction. all while being equitable, because it can't be that you're providing this to 15-20% of your patient population and ignoring the other 85% of the population, right? If you define all of those and you are highly performing on all of those, that is what I call value-based care.
Got it. Well, as always, sometimes the definition of a term can be a major theoretical and practical struggle. So, well, amazingly, we are at the end of our hour. So I just want to, first of all, thank each of you for joining us. I know we could spend another hour, and maybe next time we'll have to do that. We just barely got a taste of amazing things that are happening at each of your institutions. So Rajika and Nabil, thank you both for joining us. And Paul, again, your years of expertise and knowledge have been really helpful to illuminate some of these issues, but we've barely started to illuminate many of them. So there's a lot more to talk about and a lot more to do. All of you who are in the audience, sorry we couldn't get all your questions answered. The index is live, so have a look, and maybe you'll discover something interesting that we'd love to react to or respond to. There may be other things that we should be doing, so we'd love to hear from you about that. Those of you who don't get our weekly newsletter, Lown Weekly, you should subscribe, sign up for that. And those of you in the hospital sector, as we said before, can join us on a regular basis for Hospitals on Purpose, our weekly, our newsletter for hospitals. We're now heading into the summer season. We will be having more events, but not until after Labor Day. So we look forward to seeing you in the fall and in the coming year. Thank you all for joining, and we'll see you soon.